Good evening, everybody, and welcome to our webinar on hereditary cancer risks. We really appreciate your attendance. We are very grateful for the prior submission of questions, and we're looking forward to having questions submitted now that we try to answer. To introduce myself, I'm Pamela Munster. I'm the director of the Hereditary Cancer Clinic, and I'm very happy to be here. As my guests, I have our own nurse practitioner, Beth, Lynn, and Veronica. Fern, if you may want to introduce yourselves quickly. Beth, go first, please.
Good afternoon, everybody. My name is Beth Lynn, and I am a nurse practitioner, as Dr. Munster said, and I've been at UCSF for 6 years
Thank
in the
you.
Hereditary Cancer Clinic.
And before that as well, thank you. Veronica.
Hi, I'm Veronica Fern. I'm a nurse practitioner. I come from primary care and have recently joined the Hereditary Cancer Clinic in June.
Thank you. We also have with us Julie Mack, our chief genetic counselor and steadfast partner of mine in this program, who's been with us since the inception of the program. Julie, would you say a couple words?
Yes, I have been at UCSF now for 23 years, but as you said, Pamela, for the last 10 years, we, with your inspiration, have built, I think, just a really special place to help people through a lot of difficult information and decisions, and I'm really just proud to be part of this team.
And I think what the interaction with our nurse practitioner and with our genetic counselors have been really made incredibly valuable is the fact that recommendations are forever changing. And it is no longer in 2013 when we were first starting talking about this program. It was more a one-time visit with a genetic counselor, and that was it. And now we have a very clear back and forth, and so today we're going to talk about risk, and I'm joined by special guest, Dr. Heather Cheng, who is an expert in prostate cancer. And if you Google her, she's really world famous in the world of prostate cancer and hereditary prostate cancer. Dr. Cheng, please say a few words about you and what you feel strongly about.
Well, thank you so much for the invitation, Dr. Munster, and to be part of this forum. I am delighted and honored. I am a medical oncologist by training, and I specialize in prostate cancer and in genetics. And most of my practice has been in caring for people with prostate cancer. And since I first started on faculty, and even when I was a fellow, noticed, there were patterns and really got interested in the hereditary component. And I've now, we can talk more about this, but there's PARP inhibitors, which followed in the footsteps of breast and ovarian cancer for prostate cancer now. And so there's this interaction between treatment and risk. And I also have a clinic for people at risk for prostate cancer. And then that has expanded to a greater role. Actually, just earlier this month, I'm helping to lead the cancer genetics program at the Fred Hutchinson Cancer Center in Seattle. So I'm just delighted. And really, I think what I feel most passionate about is helping our male carriers understand their risk better and have the same or similar opportunities to be proactive for their health in the same way that, has been so nicely forged for women. And of course, we can all do better across the board with the research efforts that we have. So really happy to be here, and thank you.
Yeah, and we really particularly grateful for you to be here, because one big part of the mission of our clinic is over the next 5 years is really to deepen the awareness of hereditary risk for prostate cancer, hereditary risk for males. And I think over the last 20 years, there's been an incredible focus on hereditary cancer in women. And I think we have been a little bit less stringent and less empathetic on like men have risk for hereditary cancer. Men are fathers, men are patients, right? So I think it's important to go there. So bringing this back to Julie for a second, it's like for males, what are the most common mutations that are really clearly associated with an increased risk for cancer?
Yeah, I think my answer makes me think about the original name of our group and the Center for BRCA Research, and the BRCA genes were named for their relationship to breast cancer, but we know that they also are a risk factor for many other cancers. And Dr. Cheng is an expert on prostate cancer, and that's actually something that at the beginning of my career, we didn't have as clear an idea of the genetic contributors to prostate cancer, but we have discovered that many of the genes that increase the risk of breast cancer and ovarian cancer in people assigned female at birth are risk factors for prostate cancer. So I would say prostate cancer is way up there on the list, but you've often spoken, Pamela, about some of the other cancers that don't, have any gender association that we also need to be aware of, like colon cancer and pancreatic cancer.
And what are the main genes that come to mind when we talk about prostate cancer?
So some of them, as I said, I think that our longtime BRCA 1 and 2 that we for a long time associated with hereditary breast and ovarian cancer are up there on the list, particularly BRCA 2. And we've discovered that most of the genes that we know are risk factors for hereditary breast cancer do seem to increase prostate cancer. We can get into nitty-gritty if we want to later, but most of our breast cancer genes do. And we've also found at least one gene, HOXB13, that is associated with hereditary prostate cancer, but we don't know of any other cancers that it's associated with. Oh, sorry, because I'm talking off the top of my head, I'll also throw in Lynch syndrome, that several of the genes associated with hereditary colon cancer also appear to be risk factors for prostate cancer. And maybe I'll just step back and say also that we know almost every cancer diagnosis is what we call multifactorial. It doesn't come from just one gene or one thing in somebody's life. So when we talk about all these genes, they're not sort of absolute things that mean someone will definitely get cancer or definitely will not. But we have learned that all of the genes that I just mentioned, if somebody is born with a version of that gene that has what we sometimes call a mutation or a pathogenic variant, a change in that gene that stops it from working, we know that those people are in a higher risk group for prostate cancer and could benefit from the care of Dr. Cheng and our nurse practitioners.
So Dr. Cheng, like when you Google prostate cancer, it's the most common cancer in men in most of the world, right? It's exceedingly common. There are rumors if you live long enough, at some point you'll have prostate cancer, but you live with prostate cancer, you don't die from it. So then what's different when someone has a hereditary risk for prostate cancer? Just what are the differences in biology? What makes this different type of cancer?
Yeah, I think that's a really excellent question, Dr. Munster, and I think it's one of the things that has made it challenging. So starting with exactly what you said, which is the main risk, one of the main risk factors for prostate cancer is age. The older you get, the more likely it is that you have prostate cancer, but the majority of prostate cancer is not life-threatening. So it's very common, and that I think is what made it challenging to sort of understand the genetic component of it, because there are a fraction of patients, the ones that I see in my medical oncology clinic, that have more life-threatening cancer that we do need to do something about. And so in the era of PSA screening, which is a blood test, prostate-specific antigen, there was a period of time when we, with good intentions, felt that everyone should get PSA screening. The result of that is we had a lot of diagnoses of kind of non-life-threatening, or what I sometimes call wimpy, prostate cancer that is something we can follow and monitor without treatment, and maybe the treatment side effects might outweigh the benefits. And we also know that family history of prostate cancer is important, but other cancers like breast and ovarian cancer, for example. So I think one of the things that really changed the landscape of our understanding is separating very aggressive prostate cancer, Gleason 8, 9, or 10, and metastatic prostate cancer that is life-threatening, from the sort of more common not life-threatening cancers. And depending on how the studies were done and how carefully they curated, how aggressive was the cancer, sometimes people know that, sometimes people don't know all those details. It can kind of muddy the waters and make it more challenging to sort of see what's there. So family history of prostate cancer, family history of other cancers. There was a period also where there was a lot more focus on asking, and urology will ask a lot about family history of prostate cancer because that does increase the risk of developing prostate cancer. There's good evidence for that. Having a father or brother with prostate cancer increases your risk fourfold, sixfold, especially if they're younger ages at diagnosis. But also expanding that to remember to ask about the other cancers in the family. So men don't always think about, oh, Aunt Carol had breast cancer or ovarian cancer, and those things are really important. And part of that is encouraging everyone to be asking about the family history and not limiting to a particular type of cancer, but trying to expand.
And where are we with regard to like germline testing for prostate cancer? Do we recommend anyone who is a sister with breast cancer to get germline testing done, or like where are we? Like as you all know, it's like I'm a very strong proponent that as many people get germline testing as possible, but that's
I think the more we can do, the earlier. And I think, Veronica, you said you came from primary care, but I think the more we can find people before they have cancer, based on understanding their family history, cascade testing, those are all opportunities for being proactive, for learning more about the natural history. Sometimes we talk about in the cancer setting and breast cancer, HER2 used to be really poor prognosis, but that's because we didn't understand the biology. And so if we can find people early when their cancer is more likely to be cured and take advantage of the biological understandings we have using, PARP inhibitors, platinum chemotherapy earlier for people who have BRCA related prostate cancers, then that I think will really allow us to make more important advances, especially in the era of, we talk a lot about precision oncology, but can we also apply that to screening and prevention? And I hope so, but we also have to find and test more people at risk. So there have to be more people at risk who, for example, carry BRCA2 or HOXB13 for us to be able to do studies and understand risk and risk modification better, and things like how much does healthy lifestyle and exercise and things like that affect, the risk, and can we do more to intercept, let's say.
And can we just do make this a bit more broader? Can someone please define germline testing and cascade testing? Maybe Julie.
Yeah, absolutely. So I think now that genetics has become so prominent, as you said, people are hearing about all different types of tests, especially cancer patients are getting lots and lots of tests. And some of those may even be called genetic tests, but those are often done on the tumor. And what our kind of area or topic for this evening is the term you use, germline testing. Germline, for better or worse, is the term that we use to talk about what gets passed down from generation to generation. So the genes that you inherit from your mother and father or might pass on to your children. Testing is usually done on a saliva sample or blood sample. It's kind of meant to take a representative, healthy part of somebody's body and see what their genetic makeup is. So that's what we've been talking about here today. I was going to follow up on your question and what Dr. Cheng said. I often think about the kind of the ceiling and the floor, like the ceiling, meaning like how many people could be tested. I think you're right to say, and Dr. Cheng is right to say that is kind of endless. Like at this point, a lot of people on the, just out of curiosity might choose to do some type of genetic testing to understand their risk factors. And that hasn't been we don't have a medical guideline that puts a cap on it, although some insurance companies might put a cap and say some people, they're not going to pay for it and other people they will. And those are a bunch of other projects that you and I are working on to make it more accessible to people and connect people to, reasonably priced testing. But I think about the floor, like who should absolutely be tested, who should not miss out on this is when we talk about prostate cancer, a lot of the things that Dr. Cheng mentioned is we know that the more aggressive types of prostate cancer, I love that I've not heard about wimpy prostate cancer, but we're somewhat less concerned about wimpy prostate cancer or cancers that happen later in life. Those are more often age-related. But we are more concerned when we see these very aggressive prostate cancers, and especially in young people. And so that, the question you're asked about who should be tested, I think about anybody could be tested. There's a certain group of people who really should be tested. And you mentioned the other term you mentioned was cascade testing. So a lot of times, we don't know what's going on. We don't know why somebody got cancer, but we might do this germline or hereditary test on a blood sample or a saliva sample. If we find something, if something comes up positive, meaning one of those genes that we were, throughout all those letters and numbers, one of these genes we're interested in, and we find out that gene's not working properly, and we know that that's a gene that this person or a genetic, what we fancy terms call a pathogenic variant or a gene change that somebody inherited from one of their parents and could pass on to their kids. And so that term cascade testing is something we use to say, once we found that, that is such a powerful tool. And we actually did a webinar on that maybe about a year ago, so people could probably find that recording. It was about how to talk to family members, and just that idea that now you aren't fishing around trying to find out who's at risk. You know that this person's brothers and sisters each have a 50% chance of also testing positive, their kids. So that term we use, cascade testing, is for that family testing once we found something, and it's a really powerful way to kind of find people before they are sick and try to prevent something down the road.
Super helpful. So if someone has a hereditary risk for prostate cancer, Dr. Chen or like Beth or Veronica, what changes for that man? How do we approach this man differently? You mentioned a little bit that PSA is complicated and controversial, but what is changing for these men?
I think, one of the things that has happened, I mentioned that there was a period of time where a lot of people everyone was recommended PSA screening. And I think one of the consequences of that is we were finding a lot of cancers that might have been these kind of wimpy cancers. And so some of the guidelines have actually changed. They changed for a period of time where they said nobody should get a PSA, but what was left out of those, the U.S. Preventative Services Task Force recommendations, it was really an acknowledgement of risk. And so again, family history of prostate cancer, people with a genetic predisposition or genetic gene change that might increase their risk, those are reasons that somebody should be considering PSA or prostate-specific antigen blood testing. And we have a recommendation now for starting at a younger age, 40, if there's a gene like BRCA2 where the risk increases quite a bit, or HOXB13, another gene, if there's a change that increases the risk quite a bit. But then also clinical trial opportunities might be there for people who want to do more intensive screening and using some newer strategies.
And Beth and Veronica, what are we doing in our clinic for men with BRCA2 mutations? What do you do for BRCA1 mutations? I think there's still a bit of a difference in our approach.
So I can cover BRCA2. What we do is exceeds the recommendations from the NCCN. So whenever we talk to patients about this, we let them know that this is one of the places where we've kind of gone above what the NCCN recommends. But we have a policy that if a man under the age of 60 has a PSA that goes over 1, and those of you who are men know that a PSA of 1 is a completely normal PSA, but if it goes over 1, we refer them to a specialist in our surgical oncology department. And they have additional testing that they can do, blood tests, imaging tests, that can help more personalize and quantify risk for an individual man. And so if they do their testing and come back with what they think is a very low risk for that individual based on everything, the blood tests as well as family history, as well as imaging, then that patient will come back and we'll continue to follow them based on whatever the recommendations is for the oncologist. But if it's a higher risk, if the physician thinks that the patient has a little bit higher than risk, even given the mutation, they might decide to keep that patient within their clinic and follow them a little bit more closely. So it's our attempt to try to personalize the care for the individual based on whatever information that we have available to us. And Veronica can tell you about BRCA1. It's about the same.
I think a big part of our clinic is really facilitate a place for discussion and an early assessment of what someone might need. I think as Dr. Cheng pointed out, a 42-year-old with a BRCA2 mutation and 3 relatives with a very young prostate cancer will warrant a very intense screening. And I think we typically would loop in a urologist and a more multidisciplinary team with imaging and everything else. Someone who is like 81 and no one in the family has prostate cancer, has a BRCA2 mutation, we have a more personalized approach. I think the clinic, the hereditary cancer clinic, is really meant for us to do 2 things. Make recommendations for you that are applied for the individual based on their age, family circumstances, other risks, and mutation. But at the same time, one of the more important part is what I learned over my long career in medicine. Someone actually has to order those tests. And when someone recommends these tests and ordered them, it is a much more reliable way that these tests are actually done. And I think and Beth and her team has actually shown that if we order tests and if we see patients regularly in the clinic, what did we find? 85% of all the planned exams were done within 6 weeks of intended, which I think is really important. I think the one thing I learned over my long life as an oncologist is like there's so many patients who come in like, I just was late on my mammogram for 3 years and I felt the lump. I just didn't think it was anything. And I think we really try very, very hard in our high risk group of people that this doesn't happen. Veronica, when you see a woman with a BRCA2 mutation, what do you say to that woman about her male relatives?
So usually people get worried when they're in their 50s and their kids are approaching age of 20 or a little bit older. And so we do talk about their risks and how to talk to them, and give them the information they need so that they can pursue testing themselves. The mothers are always very worried. So, we try to help them take action on that front. And then, we're taking care of their needs too. But, to your point, people are so busy these days and they need somebody to kind of help organize their care and keep them on track. And I think that's one of the most important roles of our clinic, besides, interpreting tests and all of these things. It is getting them in for their visits and answering their questions. They tend to have a lot of questions. So, keeping on top of that for them, give them a little peace of mind.
So the other thing that I'm wondering is like Heather, how you guys approach is if you have a 45-year-old young man, do you then bring in their fathers for testing or their uncles? Because I think we often have that sense if someone is over 70, these hereditary mutations don't apply because they're not too old. Is there such a thing? Is anyone too old to worry about to have aged out of the risk, if you will?
I think for me, it's my general sense is that chronologic age does not always track with physical health. And so if someone is in reasonably good health and we would consider giving them treatment, then it seems like for a cancer that they could be at risk at, then it seems reasonable if it's within the goals of that person to be thinking about testing. So we do have people in their 70s get tested. I think it's uncommon to see people in their 80s. I can't think of somebody, but if they were really motivated and it had implications for other branches of the family, for example, that would be a reason, like aunts and uncles for cousins. So I wouldn't put restrictions on it myself, but it depends on sort of the purpose of testing, and every individual may have a different reason, and have different, relatives that could be also benefiting from that information.
Thank you. So I think we know a lot about BRCA1 and BRCA2. We know probably a little bit more about Lynn syndrome, but we have these two very common mutation, CHEK2 and ATM, where people have a little bit more struggles around what the risks are. Like, let's start with ATM. What is the risk for prostate cancer with someone who has an ATM mutation? Do you want to start, Julie, and then we talk to Dr. Cheng about this?
Yeah, sure. I am just about to pull up the kind of official statistics, but as a preface to both of those genes, I'm glad you brought them up because, as you said, we actually have a large number of people who are CHEK2 positive and ATM positive. And one of the things I want to emphasize, which I kind of touched on earlier, is that these genes don't tell us everything about somebody's risk. They might kind of shift our concern higher, but they don't tell us everything. And that's particularly true of genes like ATM and CHEK2. And for CHEK2, I'm going to add that there are many variations. There are many different types of gene changes in CHEK2. And that makes it even more complicated. So Beth had talked about how we really try, when you come in to talk to our genetic counselors and our nurse practitioners and our doctors, we really try to individualize information based on your family history and your test results put all together. And so what I'm going to quote from is actually from the National Comprehensive Cancer Network, or NCCN. And Dr. Cheng and I both, help contribute to the information here. And what we officially say for prostate cancer and ATM is that there's emerging evidence for increased risk, and that we consider additional screening. So we don't have a specific number put on that right now. I don't know, Dr. Cheng, if there's anything additional that you would, additional data that you want to add to that, but that I tend to start with the kind of official word from NCCN.
Yeah, and I think, to build on what you said, Julie, it is difficult to make, I think the data that exists is not perfect. And part of the reason I think it's challenging for men in particular with prostate cancer risk, or maybe some of the cancers, is we haven't tested as many people that, could be at risk. And so we have data from people that are affected by prostate cancer. And then we can see that there's a higher likelihood of carrying a hereditary, mutation or pathogenic variant in ATM or even CHEK2, but we don't know all the people that are out there with the variant, and then we haven't studied it in that order to say, of the people who carry it, who may develop it. We don't have that data because we haven't been testing as many men, and part of that is just the sort of the history of how, who has gotten testing in the past and the available evidence. So that's what makes it a little bit challenging to make better estimates. And even the ones that exist for BRCA 1 and 2 are not as good as we would like them to be. And I think that that's some of the work that, we're trying to do on the research side together.
And I think this is an important part of why someone with an ATM mutation should really seek us in the clinic, because what we learn is recommendations have always been shifting as we learn more about the ATM and its role in prostate cancer. We probably have learned a lot more about ATM and breast cancer, and probably not quite as a high risk as we initially thought. And but at the same time, as we learned and we adjusted the recommendation for pancreatic cancer screening in January of 2025, carriers of an ATM variant are actually recommended to have pancreatic cancer screening, and that can be either with an MRI or with an endoscopic ultrasound. And I think that has really been very telling, having the opportunity of caring for those individuals, that we can actually, after 3 or 4 years of caring patients and telling them that there's nothing to do, we now can say, like, now we have something to do, and now we change this. And I think it's really important. And I think it's important to have the genetic counselor bring this back to us, having the nurse practitioner bring this back to us. It's like, the other thing is like, and Beth, you may talk a little bit about this, is like having an ATM mutation in not only in the individual but in the spouse can really predispose the offsprings to disease. So, Beth, can you talk a little bit about the ATM homozygous state?
Certainly be happy to. For most of the patients that we see, we talk about syndromes that people can be affected by if they inherit a single copy of an abnormal gene. So there's a lot of different terms for it, and Julie's a lot better than I am, but occasionally people will inherit a gene with a mutation or a pathogenic variant in the same gene from both parents. And when that happens, it's very uncommon. It often leads to additional, really a different kind of set of medical risks that are often much more severe than what they are when it's a single gene. And so often it is not just cancer risk, but it's also medical risks of other health conditions that are not cancer related. And so one of the things that Julie will talk to people about when she does her initial counseling, and then we will talk about as we go through care over their lifespan, is as people get to the age where they're starting to think about marriage and having children, we'll talk about having their spouse checked so that we can find out whether or not they're in a situation where both carry a mutation in the same gene. Julie can probably talk a little bit better about the specific medical conditions associated with biallele ATM. Julie?
You always say that, but actually I love working with our nurse practitioners. I feel like we learn so much from each other, and you've definitely become a big genetics expert. Just again, I think Beth captured it well. Like, we know that most of the things we're talking about here are that somebody inherited one copy of one gene that's not working properly from a parent. In most of these cases, they've inherited another copy of that same gene from their other parent that's working fine. So I think, to use the example of ATM, if we say somebody tested positive for ATM, it means that they have one copy from one parent that isn't working of that gene ATM, but another copy from their other parent that's working fine. And that's why that's a risk factor for developing cancer, but sometimes people never get anything. We definitely see people who live their whole lives and are perfectly fine. Those rare cases, as Beth said, where both parents have an ATM gene change or mutation, they could both pass it on, and it causes a much more severe disease. That's actually where the gene was named for, was ataxia telangiectasia, which is the ataxia is the inability to walk, and telangiectasias are these little clusters of blood vessels, but those children are at high risk for developing cancers as well. There's not too much point to dwell on the exact condition. I think more what Beth said is that if somebody is thinking about having biological children, that we do recommend that the other biological parent, whether it's a partner or donor or whoever's giving the other half of the genes, that we test. And most of the time that other person is not ATM positive, and that whole conversation just ends. And so, as much as that's a very kind of heavy topic, and it actually applies to several of the other genes that we work with, like BRCA2, BRIP1, PALB2, that idea of a recessive disease is true for all of those genes. the Lynch syndrome genes, but most of the time the journey ends when the other parent is tested and is not a carrier, and we don't have to worry about it. For those small number of people where it is a concern, then of course we would have a more in-depth conversation.
So in summary, what Beth and Julie are saying is like, if you do have a gene that you may pass on, it is important to also consider that your partner may have a gene that they could also pass on, and sometimes passing both on at the same times may cause these children to have more disease than we would otherwise just see with one gene. So now going to CHEK2. CHEK2 is a much harder topic. So Heather, like, what do you do with CHEK2 mutations in your clinic?
For prostate cancer, I think it really sort of along the lines of what we've talked about earlier, it really is impacted by whether there is a family history of prostate cancer. I think if somebody really wants to be proactive, we can enroll them on a clinical study for screening more intensively. But if there's no family history, and there's a lot of people that could potentially be at risk, then we can take that into account and tailor the advisement. But I think it's, the nice thing about a PSA test is it's fairly easy to do a blood test. It's not quite as involved as, say, a endoscopic ultrasound or colonoscopy. So most people, I think, find that pretty, reasonable and easy to do the next time they're getting their blood drawn. So I generally, err on the side of considering it. And then the other thing that is helpful to know is just to compare that to age-adjusted normal ranges. And I think Beth maybe alluded to that earlier when she was talking about the consideration you have for, age cutoffs being earlier for people at higher risk.
So now going back to like when someone is learns that they have a BRCA mutation, we usually call it BRCA1, BRCA2, and I think most people don't go into the weeds of what exactly variant they have and is it an 1100LC or is it another type of mutation. For CHEK2, this is very different. So Julie, can you talk a little bit of like why this CHEK2 all of a sudden needs the nitty-gritty about what mutations or what variants someone has?
So all of the genes that we are talking about are genes that have a normal job in our body. And when we say somebody's tested positive, it means that that gene has stopped working in some way. It turns out that CHEK2, there are a lot of different ways to make it not work. And some of those have stronger effects than others. And this is probably true of all the genes that we work with, but we've just seemed to see it much more with CHEK2. So there are lots of different ways to make it not work, and those give us different cancer risks. So I think it is always really important, and especially in this age where we all like ask ChatGPT or we like do a Google search, it's particularly important to know that there's so many different versions of CHEK2 that we really have to look at the exact version and look at it in the context of somebody's medical history and family history.
And then what are the cancers associated with the CHEK2 mutation?
That is also a good question because, and you alluded to this already, that actually both you and Dr. Cheng alluded to this, that we always, in the world of cancer genetics, start our studies with the most sort of dramatically affected families. The families that have had a lot of cancer typically are the families that get studied a lot. Over time, what we find is that, over time, what we want to do is, again, what Dr. Cheng sort of mentioned, is see what does anybody who is CHEK2 positive look like. And so our understanding of CHEK2 has shifted quite a bit over time. At this point in time, the main cancer that we really know for sure is increased is breast cancer in people, women assigned female at birth, and all the other, and probably prostate cancer. Everything else is sort of question marky, including, I know one of the questions submitted ahead of time was colon cancer, and that data has not really borne out the more people that we looked at. There's also still a question mark about potential risk of thyroid cancer, but that is also unclear. And Dr. Cheng kind of mentioned this, I think these numbers are always tricky, depending on how common the cancer is already. And so something like prostate cancer, which is unfortunately already a common cancer, it can be really hard to detect a small increase. So right now, I would say really breast cancer is the only ironclad risk we know of with CHEK2. But again, we want to always look at individual families and individual histories to tell them, how we would take care of them.
Thank you for this. And then the other gene that there's a lot of discussion around, it's a more rare gene, is PALB2. Dr. Cheng is PALB2 closer to BRCA1? Is it closer to BRCA2? Is it close to either? It's like, how do we handle PALB2 with prostate cancer when the numbers of identified carriers of the BRCA, the PALB2 variant is just really low? I think part of the problem is it's just we don't know who these folks are, right?
Yeah, I think it's a challenge, and I think that there are studies out there which are not in agreement, which makes it challenging for the field. Some of the large studies which have been done anchored on women and breast and ovarian cancer may not have seen a strong association with prostate. I do wonder, if you looked under the hood, whether there was the same quality and attention to the details of the prostate cancer as there was for the breast and ovarian, if the breast and ovarian was the primary sort of cancers that were being studied at the time. It's hard to know. I think from a biological standpoint, I think it's a gene that in its normal function interacts. It's the partner. I mean, PALB2 stands for partner and localizer of BRCA2, and it interacts very intimately with BRCA2. And the other cancers that have been implicated seem like they resemble the phenotype or the sort of, the patterns that we see for BRCA2. So barring strong evidence otherwise, I would err on the side of treating it more like BRCA2. And I think I've been humbled because I have patients with PALB2 with advanced prostate cancer. And, so I think that's my lens, but I think that I manage them more like BRCA2.
Yeah, thank you for this because we do too, because I think the documented risk for pancreatic cancer is also elevated with patients with the PALB2 variant, suggesting it's actually a bit more like BRCA2. I can tell you from studies in the lab, it's PALB2 carriers are exquisitely sensitive to PARP inhibitors. So I think that's also therapeutically, they may resemble closely to BRCA1. So I think it's an interesting phenomenon. We are very keen on studying more patients or carriers of PALB2 variants. And I think Beth and Veronica, a little bit if you can speak a little bit to the screening, like our recommendation typically say you need to have a lifetime risk for more than 5% to qualify for guideline-driven screening. But can you talk a little bit more, like how do you screen for pancreatic cancer and what do we do with what studies are available and what can people do?
Veronica, do you want me to take this one? Okay. So pancreatic cancer screening guidelines, obviously they vary by the mutation. And currently there's a couple of mutations where it's recommended or to at least consider screening for everyone once they reach the age of 50. In fact, I think there's at least one mutation where it's younger than 50. There are also a number of mutations where the recommendation is based on family history. So if there's a family history of first or second degree relative, so a direct relative like a parent or child or sibling, or second degree is like grandparents, aunts and uncles, that somebody it would be recommended that they consider screening. The primary screening that we use for pancreatic cancer is annual screening with one of two different kinds of imaging. One of them is a specialized MRI of the abdomen. It's called a MR choliopancreatography, and it took me 2 years to be able to say that. And it's a MRI that when it goes over the middle part of the abdomen and looks at the liver, the pancreas and the gallbladder, the machine slows down, takes pictures very close together, so it's got very good resolution. And then the software behind the scene can recreate images of the pancreas and the ducts of the pancreas in 3D. And so the radiologist can get a really good look at the ducts to identify anywhere where there's any abnormalities. The alternating kind of screening is something called an endoscopic ultrasound, which is a procedure that's done under sedation. Think if you've had an upper endoscopy, it's a procedure where they stick a device, you're sedated, they stick a device down the throat into the stomach. Normally, it's used for evaluating the stomach for bleeding, ulcers, different kinds of things, and evaluating the esophagus. But in this case, the device is equipped with an ultrasound wand, and they go down to the bottom, kind of into the stomach, and the ultrasound downward. And guess what? The pancreas is right below the stomach. So they get really good imaging of the stomach, of the pancreas. So those are the two primary imaging. It's interesting, in other countries, there are sometimes other things that are used. For example, there is a lot of research that's looked at the occurrences of adult onset diabetes, followed not that long afterwards by a diagnosis of pancreatic cancer. So the international guidelines recommend that the hemoglobin A1C blood test, which tracks average blood glucose and is used for screening for diabetes, that test be monitored for like significant changes, because it's not common in adults to have really big changes unless you change your diet a lot or you change the amount of exercise you're doing a lot. So when we talk to people, we talk to them about the recommendations in NCCN. We let them know about the international recommendations in case they want to do something else. For people who don't qualify for screening because they don't have the family history and they have one of those mutations, we talk about at least doing the A1C as something that they can have some sort of screening that goes on.
And we do talk about lifestyle changes as well, and avoiding smoking, avoiding a lot of alcohol, staying fit, doing exercise.
Veronica, when you say avoiding a lot of alcohol, what do you mean by this?
Well, the current recommendations are zero alcohol. And, in the Bay Area, people drink a lot. So I think the current recommendation is if you're going to drink, no more than one drink per day for a woman and no more than two for a man, and not to drink every day. So we do know that alcohol is related to cancers.
Yeah, and I think I think these recommendations are still probably emerging more strongly. It is also fair to say that our younger generations are doing much better. Alcohol is way down. I think if we talk to Californian winemakers, they're quite dismayed about the fact that people don't drink as much. So I think in breast cancer, we have studied the contribution of alcohol to breast cancer for decades. We don't have a conclusive answer other than less is better. But I think we spent whole conferences on talking how big is one glass. When you say one drink, well, how big is that glass? Mm-hmm. So I think we don't know, and I think it is also fair to say alcohol is very often linked to other lifestyle modifications that could be beneficial. So I think as little alcohol as you could get by with as a participant who is at risk, that is probably something to strive for. When it comes to the hemoglobin A1C, and Veronica, you've taken this from the primary care. I think hemoglobin A1C is an excellent thing to test. If you find a change and you don't find pancreatic cancer, that is wonderfully reassuring. But if you're diabetic at the age of 50 and you go for 2 decades without treating your diabetes, that is not good medicine. So I think it's really important. I think it's one of the most important tests we can do. We can actually modify this. Before we go into the lifestyle modification and all the good and self-righteous things we can recommend as doctors, Dr. Cheng, tell us a little bit more about the PARP inhibitor and prostate cancer. And we talk about the PARP. There's a lot of questions. Are PARP inhibitors ready for prevention? We do risk-reducing surgery for breast cancer, but that's not quite as easy in prostate cancer, right? So no one would recommend to take the prostate out prophylactically.
Yeah, I think there have been some discussions about, if there's a high-risk gene such as BRCA2 with a very strong family of history of cancer, would we consider that? And I think that people find it intriguing, but I don't know that anyone's quite ready. There's, I think, one case report and some discussions about a trial looking at that. But you're right that prevention is not has not been part of the discussion as much for prostate. Although a number of years ago, they did look at 5-alpha reductase inhibitors. And I think what the conclusion to those studies was that there was a decrease in maybe less aggressive cancers, but not as much impact on aggressive cancers. And whether, depending on how you interpret that, it could be that it just wasn't as effective or gave rise to more aggressive cancers persisting. I think we haven't really been using those, but there are, I think, with more testing and understanding of risk, will be more opportunities to begin to ask those questions in a more systematic way. Part of the challenge has been just not having better tools for better risk prediction. And we haven't talked about yet, but is on the horizon, maybe in breast and breast cancer, a little bit more ahead of us, because in many arenas is polygenic risk. But I'm getting a little aside from myself because you asked about PARP inhibitors. So PARP inhibitors are drugs that are approved for prostate cancer now. Actually, in 2020, there were 2 that were approved. The first one was olaparib. The second one was rucaparib. And then we have combinations now, abiraterone, which is a hormonal drug, together with olaparib, and niraparib with abiraterone, and then enzalutamide with another hormonal drug with talazoparib. So there's now some combinations, hormonal therapy with PARP inhibitors. And the biology and data suggests that they're very effective, especially effective, I think, for BRCA2 and BRCA1 and PALB2. Although there's one study recently where it's maybe less clear for PALB2. So I think not all the studies are in complete agreement. Some of the PARP inhibitors have slight differences in their mechanisms of action. And so, sometimes there's discussion about, is it the dose that mattered? Is it the specific PARP inhibitor? But it's great to see options. And I think, I have many patients who are doing quite well on PARP inhibitors and able to, go and live their life and travel and have their cancer under control. And that's really wonderful to see. So those are being moved earlier. We had a study looking at PARP inhibitors in the biochemical recurrent setting, kind of intriguing. I'm not sure it's made it into prevention yet for prostate cancer, for people at risk for prostate cancer, because in part, again, the rate limiter is we don't have as many people that are tested that are at risk. So if we call this group previvors, we don't have as many male previvors as we do for women. So it makes it really challenging to do those kinds of studies. So I think a lot of what I think about is trying to get more people tested so that we can begin to ask those questions and do those studies and move the needle there. So the first place is getting more people tested. And then I think and then maybe we'll have some data in the breast and ovarian cancer realm that we can sort of take advantage of.
Yeah, I think just to point out, because looking at the questions that we have is like, the risk for breast cancer really starts in the 20s. I think we can probably safely say the risk for prostate cancer starts in the 40s.
Yeah.
And so there's just 2 more decades of risks. And I think, it's often a question for someone who's young. So why don't we do a PSA in their 20s? Because they could be prostate cancer. So why don't we? I think it's sometimes hard to understand why we don't do these screening tests. What is the downside of doing a screening test in someone who's very young?
I think the likelihood of, I think it's extraordinarily unusual. I can think of one person who was diagnosed, two people under 40, one of whom was in their 20s, but that person had a TP53 mutation. So a little bit of a different class even of the ones we're talking about mostly today, the BRCA1, BRCA2, and Lynch genes. Prostate cancer, the recommendations for starting at 40 acknowledge the fact that even with BRCA1 and 2 carriers, the majority of cases are still in the 50s and 60s or higher. So 40 is still unusual. If there's a family history of somebody who was affected in their 40s, we can adjust. We generally do adjust the screening to start about 10 years earlier, but in the 20s would be more likely to, I think, not know how to manage that. And it does lead to biopsies, which I think people are generally unenthusiastic to have prostate biopsies if they're low yield and unlikely to have cancer. Even people who have sort of a somewhat concerning PSA may prefer to have imaging first to do a biopsy, but maybe similar to like mammograms, younger age may have different appearance, and dense breasts may have their own set of nuances and interpretation. So I think the yield is lower for starting PSA at least that young.
Mm-hmm. And then going back a little bit more to the other mutations. So what about colonoscopies, Beth or Veronica? When do we start to do colonoscopies, and who should get a colonoscopies under the recommended age of 45 for all comers?
So it's the same sort of deal. The general population guidelines at 45, but if you have a family member who had colon cancer at a younger age, then you start the screening 10 years prior to that age. Would you like to add anything, Beth?
Well, the thing I was going to add for that, we haven't spoken very much about Lynch syndrome. Lynch is actually the most common hereditary cancer syndrome that nobody knows about, unfortunately, because the cancer pattern of colon cancer, sometimes stomach cancer, ovarian, endometrial, it's a kind of a mixed group. And it doesn't get recognized as much when healthcare providers look at a patient's medical history. They don't always recognize that pattern is going on. So colon cancer screening for people who have Lynch starts at 30 to 35, and sometimes is even younger depending upon the family age, the family history. There's other mutations. Dr. Cheng was referencing TP53, or also known as Lee-Fermini syndrome. That's another one where colon cancer screening starts quite young, in the 20s. There's other mutations where screening starts in the 20s. And these are people who often, their first colonoscopy, they have many polyps. There are also hereditary syndromes where it may not necessarily be a risk of colon cancer, but it's a risk of significant numbers of polyps. And those people also start getting colonoscopies much earlier, because even though a polyp is not cancer, lots and lots of polyps can cause lots and lots of problems because they can obstruct the colon.
And I think as we see a surge in young colon cancer, it's quite important for anyone to be an advocate for themselves, because we do see a lot of young people come in with colon cancer who have been telling the healthcare provider for months that they have some changes in their colon habits, some blood, and I remember when I started my career as an oncologist, mainly in breast cancer, that we heard all these young women come in and said they were told they were too young to have breast cancer. I think we have really educated the public and healthcare providers that one is never too young to have breast cancer. I think we need to extend the same as that no one is ever too young to have colon cancer. I think that's a new barrier, and I think men with a very strong family history of prostate cancer should be screened, should get germline testing, and should get different screening. I think. And germline testing is really easy now. Dr. Cheng, what do you do? What do you recommend if someone wants to get germline testing? How do you get it done at the Hutch?
I think we have a few paths. One is we can refer people to genetic counseling, colleagues of Julie, who can go through sort of pre-test, doing a really good family history, talking about the risks and benefits, and going through insurance considerations and so forth. And we also have a program through our prostate high-risk multidisciplinary clinic, because this is so important and because there's not enough people like Julie in the world. Genetic counselors have limited capacity and longer wait times, is that we have a program that's sort of like mainstreaming or point of care, where people are informed in advance and at the clinic and have basic information about testing, and they can opt, if they feel comfortable, to go ahead and collect saliva or blood at the visit in order to get the testing done more quickly. And that's usually either through an in-house test called BRCA or through Ambry, depending on the insurance situation. And one of the reasons why that's important is we have a clinical trial of a neoadjuvant treatment before surgery. So knowing about whether somebody is a BRCA1 or 2 carrier is important in understanding their options for treatment. So timing kind of is really important in that instance. And that's given us an opportunity to learn about how to deliver genetic testing more in a different way, where more people have access and don't have to wait. And then, of course, they meet with Julie's counterpart, genetic counseling, after the fact if there's an important finding.
Julie, how is it? How do we do the testing? What's the easiest way in the Bay Area to get tested, or at UCSF? Or
I think very similar to what Dr. Cheng said, is we have a full range of options. And when we say the easiest, I think one of our challenges is that what's easy for one person could be hard for somebody else. And definitely for our cancer patients, we also have mainstreaming in place where their oncologist or surgeon or one of the nurse practitioners or other professionals that are working with that cancer patient can just order the testing directly, because it's so important for their medical care. And usually those are people who, if you ask them, do you want this test? If they know it's going to help with their cancer care, they don't have a lot of questions or hesitations. So I think that going through your medical provider if you have cancer is one way. As Dr. Cheng said, we also still have our genetic counselors, and a lot of times that is a better fit for anybody who is hesitant, has a lot of questions, and especially some of our young people. I was just looking at my calendar for tomorrow, and there's a couple of people in their 20s who have a family member who has a positive test result, and they have a lot more questions and concerns about the timing of testing, what information they want to get, how they're going to use it. So I think that what we really want is to have the full range of options and have people fall onto the path that makes the most sense for them.
Thank you. Beth, Veronica, anything to add to the germline testing?
I feel very fortunate that we have Julie and her team, because they manage a lot of testing before they get to us. It helps streamline our job so that we can focus on other things.
So before we go into the more lifestyle choices, Julie, can you remind people again what a true negative is? Because I think it's an important part that we need to get across. And why testing? I know a lot of people don't want to be tested because they don't want to know, but there is actually very strong benefits from knowing that you don't have a mutations. Do you mind speak into this
Yeah,
again?
absolutely. So I think even though we are focusing our conversation on those families where we have identified a specific genetic cause for the cancers, we've also mentioned that a lot of cancers, we don't know why they happen. And that's the majority of cases. In these families where we have found a specific genetic cause, as you said, a lot of times people are hesitant to do genetic testing because they don't want to hear bad news. They might have a lot of understandable fear and trauma from watching their close family members go through cancer. And that comes back to, and Beth and I threw out a lot of genetics at you today, but remembering that if somebody's tested positive, that means they have one copy of the gene that has a change that is increasing their cancer risk and another copy of the gene that's working fine. And when they had kids, they could have passed on the one that had the cancer risk or the one that didn't. The people who did not inherit that gene change in their family are the people that we call true negatives. And that is a really important, that's 50% of the people in a family where there's a known genetic cause for the cancer. So absolutely, we think it's, and that's a good example of where not everybody wants to talk to a genetic counselor, but I think more of those people do for making that decision. And we can help them kind of talk through that and make a plan. But it is, yes, definitely really, really good news. And, something that people sometimes almost have difficulty, I think, believing when they've spent years or decades watching their family members be sick. It's almost, unbelievable to know that they aren't at high risk as well.
So Dr. Cheng, following this thought, if you had a 45-year-old that you've been screening for PSA and his brother tests negative for the BRCA mutation, do you feel comfortable telling that individual that he doesn't need to be screened at 45?
If there is a strong family history of, I actually would say, well, I have a couple, if the person affected had BRCA2 with early prostate cancer and there was no one else in the family, then perhaps, but the average risk person guidelines is at 45. So I think it doesn't hurt to still, there are other causes of prostate cancer, and people can still get prostate cancer without one of these cancer risk genes. So I wouldn't, if there's a family history, I would still probably follow population recommendations for screening rather than the more intensified or earlier screening. But one thing I wanted to mention and follow up what Julie said is it's also important, and I say this because I've had at least one patient for whom this happened. There was an actual BRCA2 in a family, and then somebody did recreational testing. And by that, I mean, not a medical test. They did 23andMe and did not carry the mutation, but the family mutation wasn't actually, would not have been picked up. And so I think with negatives, if you're not sure, you should definitely bring it to your doctor and make sure that it's the scenario that Julie talked about, and not that, because sometimes I think people get the answer that they want to get and may not have had the best test. So that's,
and I think, and that is actually a very good point, because that actually is true for me. I had 23andMe testing early on when it first came out, and my breast cancer risk was very low. And my BRCA2 mutation was not picked up because I'm not Jewish. And I think the 23andMe, the small print says very clearly that if you're not of Jewish descent, the BRCA, BRCA 1 and 2 testing is not that valuable on the 23andMe. But that's sometimes hard to discern. I think if you do the germline testing, please do it in one of the approved tests for germline testing, not Ancestry, not anything, not 23andMe, because a negative test may not mean that you're not at risk. So, and following up you thought, Dr. Jen, about if I have a young woman who had breast cancer and who is 31, her sister, and she carries the BRCA1 mutation, her sister doesn't. For that young woman, there's this massive implication, because we now would no longer recommend risk-reducing mastectomies or risk-reducing salpingo-oophorectomy, meaning taking the ovaries and tubes out. And we will probably start doing mammograms as the regular population would do. Is like, I think that the difference in the breast cancer approach for BRCA 1 and 2 is just a bit more magnified, but I think the principle is the same. I think, being a true negative really means that the screening can be relaxed a little bit and the risk is probably somewhat mitigated. So I do think being a true negative is really good news. It's not completely like without removing all the risk, but it's really good news. Okay, before we go into lifestyle, Beth and Veronica, anything else to add on like mutation, risk reducing surgeries, recommendations, anything we should add here?
The only thing I'll add is please make sure that you're regularly seeing someone. If you're in our clinic, Veronica and I will tell you if anything changes. If you're not in our clinic, go see your genetic counselor periodically, then they can keep you up to date on any changes. These guidelines do change, the recommendations do change. We learn more about things that can reduce risk. And part of the benefit of having all these people who keep their eye on it is you can come to us and we can let you know what's going on.
And always consider this is true for us, and I'm pretty sure it's true for Dr. Chen's clinic as well. If you've seen her every year for like 5 years and then all of a sudden you don't have a follow-up visit, that's not because she doesn't want to see you anymore. I think something has glitched in the scheduling system. So I think please, if you have a hereditary mutation, we see you every 6 to 12 months. It's like, and if you're not getting invited back, it's because our system has glitched, not because we discharged you from our clinic, because that is a very clear conversation when we discharge someone from our clinic because they have absolutely no more risk. So that I think that's rare. So going back to lifestyle chances, Dr. Cheng is like, is there a magic diet for prostate cancer prevention?
I don't know if there's one single magic diet. I think that generally we advise, Mediterranean diet or minimizing processed foods, minimizing deep fat fried foods. Those have been implicated in increased prostate cancer risk. I think earlier, I don't remember if it was Veronica or Beth who talked about healthy lifestyle, but that's really important. Both, the dietary patterns are sometimes difficult to discern because there's a lot of other healthy habits that go together with certain diets. But I think generally maintaining healthy weight and exercise does have a lot of data for that. So we can talk about that later. But for diet, I think, avoiding the things I mentioned. There is some suggestion of cruciferous vegetables like broccoli and Brussels sprouts being beneficial, lycopenes in tomatoes, and certain types of mushrooms as well. But I think those are harder to prove. But certainly, if you enjoy eating them, then certainly not discouraged from incorporating them into your diet.
And with the mushrooms, you're not alluding to the more spirit-lifting mushrooms, right?
No, unfortunately, there hasn't been that association.
Okay. So, and then what about what about supplements? There's a lot of talk about supplements. Is there any supplement that has been really promising?
Well, there were a number of supplements that were not ultimately not promising, like selenium was one of them a number of years ago that was studied.
I was part of that study.
Were you? Yeah. The
leukotrienes were studied too, right?
I can't think of any supplements that I think have really stood out from the others. The one thing that it's caught, and this is more in the prostate cancer setting rather than in the risk setting, is some of the supplements do have testosterone, so you have to be a little bit cautious about that if you're on treatments to suppress testosterone.
So how strong a driver is testosterone for prostate cancer?
It's I think universally if there is advanced disease or if there's settings where there's high enough risk, we use testosterone suppressing therapies, and they do generally universally work even with very, very aggressive advanced prostate cancer. So unless the histology is very unusual, if it's an adenocarcinoma or sort of the vast majority of prostate cancers are sensitive to testosterone suppression. It's the major signaling growth factor axis. And a lot of the effective treatments, even with metastatic disease, are around blocking that signaling pathway, the androgen receptor pathway. So really well, but it also has side effects similar to, I think, breast cancer when you're modifying estrogen and progesterone. But I would say it's probably even more so. There's not the same entity of triple negative in prostate cancer. All cancer, pretty much all, we start off with testosterone suppression if it's advanced enough.
So in your expert opinion, if a BRCA2 carrier at 45 comes to see Veronica and is on testosterone, is she cruel and unfeeling if she tells that individual to get off the testosterone?
If there is no evidence of cancer and the patient is being monitored,
just a high risk.
Yeah, then I think, in that situation, I think it's a discussion about risks and benefits. And I've had patients who are on testosterone supplementation, even with high risk. And as long as we're monitoring and we agree on sort of the framework of if this, then I think it's that person's decision. And there certainly are quality of life benefits for testosterone and quality of life implications when we remove it. There's no question about that. So I don't think there's an absolute, but certainly a detailed discussion with that person and considering those is what I would advise.
So Beth and Veronica, is that good for you guys? Because this often comes up, right? And we don't really know how to deal with this.
I think it's interesting that the conversations that we have about hormone supplementing for women who are at risk of cancers that can be stimulated by hormones is pretty much the same conversation that Dr. Cheng's having with the male patients about testosterone. I think hormone replacement therapy for women is a kind of an evolving conversation right now. Those of you who are in our clinic have heard me rant about studies that have been done that have led people to believe that all hormone replacement therapy is bad. Those studies, Women's Health Initiative, after it was published, women like me were denied hormone replacement because no, it's going to cause breast cancer. We know better now, and the thoughts about hormone replacement therapy after menopause and for how long is evolving. There's always a conversation with our patients about the potential for increased risk of breast cancer. And we talk to them about the regimen of hormone replacement therapy of estrogen as either a patch or sometimes orally, but using an IUD instead of oral progesterone so that we reduce the body's exposure to progesterone. Because Dr. Munster, I'm sure you can talk better about the biology of this, but we've found that estrogen and progestin actually has the potential of increasing breast cancer risk more than estrogen by itself.
Yeah, I really appreciate this. So I think the villainization of estrogen replacement therapy has done a lot of damage to people, and I think we're now finally coming from under this. And I think the important part is it is our duty as healthcare provider to alleviate symptoms and suffering and mitigate risk for cancer. I think that's our foremost goal. In order to accomplish this, I feel very strongly we need to have an honest conversation that cannot be dogmatic, and it has to be based on the best available data that we have. And I think we are there I think we're slowly there in the estrogen replacement therapy, right? I think we have better data. We don't villainize. We we see the benefits, we see the risks. And I think it's important for the same for men is that men don't have to feel they cannot tell us about their testosterone replacement, because a lot of people are on testosterone replacement therapy. And everything in life is about risk and benefit. And I think we want to be partners in that discussion with you. We don't want to be your adversaries. Like, we want to be partners, right? I think and we want to be the guide that helps you figure out what is good risk and what is not good risk. And so I think that is really important in this discussion. So Heather, I'm very happy that you're not feeling dogmatic about like taking people off testosterone therapy when they're just at risk, not having cancer. Having cancer is different. So let's spend the last 10 minutes on exercise, because there the data is overwhelmingly strong and the benefits, right? Heather, you want to talk a little bit about that?
Yeah, there have been a number of actually studies, some from actually one of the seminal studies is from UCSF, I think, um, showing that men stage for stage, if you match them, the people that get at least 30 minutes of exercise where they get their heart rate up, those men live longer. And I think that there's also data to say that the risk of recurrence is reduced. So if you have had surgery to cure your cancer and you want to really optimize your lifestyle, frankly, and your prostate cancer outcomes, then exercise is really, I think, an extraordinarily valuable tool. And I think of it sort of like medicine. I think all stages, whether you're at risk, whether you are a survivor, whether you are receiving treatment, it's so helpful for many reasons. It can really mitigate the side effects of testosterone suppression if that's what your treatment plan involves. And I also think it's a healthy outlet for people's worry and need to have some control over a situation they may not have all the control they want to have over. I think that it's a good way to channel. Sometimes people can go down rabbit holes of investigating this supplement or that supplement, or this diet or that diet, and I try to tell them, well, that's all fine, but the thing we have the best data for is exercise. So if you aren't already doing that, then that's what I think you should focus on. Probably that's true for breast and other cancers as well. But it's always, within, as long as it's not causing you pain and you're doing it safely, it's always part of the best plan.
Interesting is like for breast cancer, I think the exercise has been beneficial and that data is established for many years. I think what's always been really striking to me, how little you need to do to have a benefit. You do not need to quit your job and exercise 7 hours a day. It's like 30 minutes of very brisk walking, or any exercise that gets your heart rate up for 30 minutes, 3 to 5 times a week, has an enormous benefit. And I think, and if you just go park further away when you go shopping, that probably would just be a big contribution to it. This is true for breast cancer, it's true for prostate cancer, and I think our Canadian colleagues presented data earlier this year that in men and women who had colon cancer and had taken the colon cancer out and had adjuvant chemotherapy completed, if they exercised regularly, they had an almost 7% difference in survival at 96 months. It's just really a very striking benefit in survival. Not anything other, just brisk walking. And I think a big part of cancer prevention is buying a good pair of sneakers. And I don't think I have that much more to say. I think we had an amazing discussion. Like I'd like to do a round of best share your thoughts about the clinic, what you feel strongly about, what you think is missing, and then we go around before you close up.
Thank you. First, I appreciate the opportunity to talk to everybody, and I think we've had a really great conversation. In our clinic, one of the things that we say the first time you come in, and we try to say almost every time we see you, is that you need to trust yourself. And if something doesn't feel right, let us know. One of the Dr. Munster told me when she hired me, she said one of the most important things is we do not want women to feel like when they have something going on in their breast that they don't have a place to go. And so whether it is one of our male patients who's having changes in urination or back pain that seems unusual and just doesn't feel right, whether it's GI problems, if you have colon cancer risk, you need to trust yourself. And if you feel something really is not right, come see us or talk to us and let us order whatever labs or imaging or do the exam that we need to do to make sure that you're okay. That's what we're there for, is to do that. Veronica?
Thank you.
Always the mute button. One thing I really love about the HCC is that it follows people throughout their lives, and it's very comprehensive. We're looking at all their risks. We're trying to keep them on track, but we're learning about their other symptoms too. We do a full symptom review, so we learn about other aspects of their health. As nurse practitioners, we also attend to their psychosocial needs, and there are a lot. When you have hereditary cancers, there's a lot of turmoil. And I love being part of a team that helps people through these difficult conversations, through these difficult decisions, risk-reducing surgeries. That's a really tough thing to talk about with a 20-year-old or a 24-year-old. And I feel privileged to be part of that conversation. I'm excited to hear about the initiative for men's health. I think that's very exciting, and I look forward to hopefully recruiting more men so that we can raise those numbers of people who don't have cancer but have those hereditary genes. I think that's really important for our field. So thank you, everyone. I've learned a lot tonight. I appreciate everyone's inputs today.
Julie?
I think we're coming up on the 10-year anniversary of our clinic, and I do agree that we have a lot of growth that is still needed. But I commented when the clinic started that I think I saw more men in the first year than I had in the previous 14 years of being a genetic counselor. So I do think that having that the message is getting out there, and I think having a concrete action that can be taken with our nurse practitioners has really helped. I think my wish is one of the ongoing ones that we all have is to really increase cascade testing. And I'm not going to use a name, but I will I think this person will know who they are. I'll give a shout out to someone who I can see on our attendee list who has called me up every time a family member is visiting from another country to try to get testing done. And I know it's really a difficult conversation, and I know that I don't want to put the responsibility on anyone in this room to make their family members do something, because of course it's their individual choice. But I think the more that we can maybe circle back to that conversation over time when things are not as intense as they were at the beginning. Maybe we can create those opportunities like this person that I can see on our attendee list, to say, oh, this person's visiting, I just want them to have a conversation. The more that we can help get cascade testing done, everybody knows mathematically that is our best way to help prevent cancer from hereditary cancers. So yeah, would love to. I think that's an area that we're still working a lot on, and I'm here to help.
What Julie is saying, if you have a mutation, that your first degree relative has a 50% chance of also having the mutation or the variant. So I think that is very high yield for testing. So yeah, thank you, Julie.
Yeah, and I guess I'll just say that we're happy to talk to people. As we kind of said earlier, there are people who are just like, I just want the test, let me do it. And there are people who are really, really hesitant, and letting them know that they could talk to a genetic counselor just to get some information and not be pressured into anything. That's one thing that we're here for. So, and all of you are, the messengers that can help bring this to your families. Let us know how we can help.
So, Dr. Cheng, before I let you say a few words, it has been an incredible pleasure to have you. I've admired you from afar for many years, as you know. You have contributed so much to this field in prostate cancer. And it was always a lot easier to make strides in breast cancer because a lot more support, a lot more awareness. So I think we cannot be more clear how hard this must have been for you to be a pioneer in that. So thank you for that, and we can't thank you enough. And just one brief shout out for Danielle, who made our flyers, for Brian, who does our AV, and Lou, who's done all the questions and answers and brought us together. So thank you very much. So Heather, the closing words are yours.
Oh, well, gosh, I think I would echo everything that's been said so far. And I guess my hope, and I'm so glad to be part of this. And I'm so, you all in the audience are so lucky to have this clinic and these experts at your doorstep and at your, to help you. And I think it's a real example for what's possible for people at risk and what we can do about it. And my big hope is that for men, that the more we can do and the more support that we have and the more opportunities we can provide will give them more motivation to come forward. And that would be true for all manner of cascade testing, or, just even people who don't have a family history. I think just having that knowledge be power and opportunities rather than burden. The more we can do about helping educate people about the possibilities for it being proactive, I hope we can do more together. Thanks.
Thank you very much, and thank you all, and to all the participants. I hope this was helpful, and we see you soon in another webinar. Thank you. Good evening.
Bye. Thanks, everyone.